1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, start of
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Imagine a patient comes into the emergency room. He's 24 years old. He is stiff as a board, he's sweating profusely, and his temperature is reading like 104 degrees.
Wow. Yeah, that's terrifying.
Right. And if you look at that and just think, okay, well, he's got a severe infection, let's just give him some Tylenol and some IV fluids. I mean, he might be dead in a few hours.
Yeah, absolutely could be.
But if you happen to look at his chart, and you see that he was recently prescribed a medication called haloperidol, and you recognize that this isn't an infection, but actually a massive neurological crisis, well, you might just save his life.
Exactly. And, that difference right there, that's psychiatric clinical judgment in a nutshell.
Which is exactly what we're getting into today, because for anyone stepping into the psychiatric milieu, whether you're a nursing student staring down just this colossal textbook chapter on neurobiology and psychopharmacology, or, a practicing nurse trying to keep a floor of patients safe, the sheer volume of information can just feel like drowning.
It really is. I mean, psychiatry is the ultimate high-wire act of nursing. We usually crave the tangible in medicine. Like a broken bone gives you a crisp, undeniable, jagged white line on an x-ray, right?
It's binary. It's broken or it's not.
Exactly. But psychiatry completely strips away that comfort. We're dealing with the most complex structure in the known universe, the human brain, and we're trying to fix it when, the wiring gets crossed or the chemicals flood the system or the receptors just shut down completely.
And you're trying to memorize receptor affinities and side effects and dietary restrictions and legal holds all at the exact same time. It's too much.
It is.
So our mission today for this deep dive is to cut through all of that noise. We were going to distill this down into an elite, high-yield masterclass, just the stuff you absolutely need to know.
We are operating strictly on the 80-20 rule today. Because honestly, in clinical practice and on standardized board exams like the NCLEX, you don't really get tested on when a shift goes perfectly.
Yeah, they don't care about the easy days.
Right. You are tested on your ability to catch the red flags, before a patient coding or seizing forces your hand. So 20% of the pharmacology concepts actually dictate 80% of your patient safety outcomes.
I love that framework. We are totally ignoring the fluff today.
Yeah.
We're hunting for the highest risk patient safety issues, the most critical meds, the exact nursing priorities, and those red flags that demand immediate intervention.
Yes. But we aren't just going to list these things off like we're reading a table of contents.
Right, because if I just try to memorize that, like drug A causes side effect B, it just falls out of my head the second I walk out of the exam room.
Exactly. We need to understand the why. That is the crucial pivot from being a novice student to an expert clinician. The why is everything.
Make it make sense.
Right. If you understand how a specific medication physically alters the chemical soup inside a patient's brain, then those side effects stop being just a random list to memorize. They actually become the logical, totally predictable result of that chemical shift.
Okay, so let's lay the foundation for that chemical shift. Before we start administering heavy psychotropics, we kind of need to understand the hardware and the software of the central nervous system.
Let's do it.
So I want to start with the hardware, the brain structures. We obviously aren't neurosurgeons, so what are the priority areas a psychiatric nurse actually needs to care about?
Well, we can really narrow it down to a few major players. First, you have the frontal lobes. This is basically the executive suite. It houses your working memory, your ability to plan, your moral reasoning, and your impulse control.
It's the filter. It's the part of the brain that says hey, maybe don't say that out loud, or we need to put our shoes on before we walk into the snow.
Precisely. And when the frontal lobes are compromised, whether that's by trauma or dementia or a developmental disorder like ADHD or schizophrenia, you see this profound loss of organization and behavioral regulation.
Wow. Okay. What's next?
Next, we look at the limbic system, which actually sits deeper in the brain. This includes things like the amygdala and the hippocampus.
So the emotional centers.
Yeah, this is your emotional core and your memory processing center. So when the limbic system misfires, you see the massive emotional dysregulation that's so characteristic of like acute mania, severe panic disorders, and PTSD. It is the raw, unfiltered emotional engine.
Got it. And then there's the locus coeruleus, which, I mean, sounds incredibly obscure, but the sources we looked at emphasize it heavily.
Yeah, it's a tiny cluster of neurons in the brainstem, but it has a massive job. It's the primary site for synthesizing norepinephrine.
Okay, so what does that mean in plain English?
Think of the locus coeruleus as the brain's internal alarm bell. When it triggers, it just throws the body into a state of stress, hyperarousal, and panic. It is heavily, heavily implicated in anxiety disorders.
That makes total sense. And finally, the cerebellum. We usually associate that purely with physical balance, right? Like passing a roadside sobriety test. But there's a psychiatric link, too.
There is, and it's all about dopamine. The cerebellum helps coordinate smooth, purposeful muscle movements, but it requires a steady supply of dopamine to do that effectively.
Oh, I see where this is going.
Right. If that dopamine transmission is interrupted, either by a disease process like Parkinson's or artificially by the antipsychotic medications we prescribe, the patient loses that smooth coordination. They become stiff, they shuffle, they get these severe tremors.
Which perfectly bridges us from the hardware to the software, the neurotransmitters.
Yeah.
I always visualize neurotransmitters as like physical keys and the receptor sites embedded on the outside of the neurons as the locks.
That's a highly accurate visualization, actually.
So a neuron fires, it spits out a bunch of keys into the synapse, which is that empty space between the cells. And those keys float across and slide into the locks on the next cell to pass the message along.
Exactly. And those keys generally do one of two things once they unlock the door. They either excite the next neuron, telling it to fire and pass the signal on, or they inhibit the next neuron, basically telling it to stop and quiet down.
Okay, let's run through the 5 major keys in our psychiatric key ring. We've got dopamine, serotonin, norepinephrine, GABA, and glutamate. Let's start with dopamine.
So, dopamine is our first major excitatory neurotransmitter. It regulates complex movements, motivation, cognition, and the brain's reward pathways.
And in the psychiatric realm?
In psychiatry, dopamine is basically the central character in the story of schizophrenia. The prevailing theory is that overactive dopamine pathways are what cause the terrifying hallucinations and delusions of psychosis.
Okay, then we have serotonin. Now, I think most people associate serotonin with, like, the happy pill concept, but it does way more than just regulate mood, doesn't it?
Oh, it does. Serotonin is largely inhibitory. It acts as a massive regulatory system for mood, but also sleep cycles, food intake, temperature control, and even pain perception.
Wow.
Yeah, so deficits in serotonin are the primary drivers of major depressive disorder and severe anxiety.
Next is norepinephrine, the fight-or-flight chemical.
Yes, another excitatory key. It sharpens your attention, impacts learning, and elevates mood. Too much of it leaves the patient in this constant state of agonizing panic and hypervigilance.
And too little.
Too little leaves them profoundly depressed and lethargic.
Okay, then there's GABA, gamma-aminobutyric acid. I feel like if norepinephrine is the gas pedal, GABA is the emergency brake.
That is the perfect way to put it. GABA is the central nervous system's major inhibitory neurotransmitter. Its entire job is to modulate and calm down other brain systems. When a patient is having a severe panic attack, their brain is desperately lacking GABA activity.
Got it. And finally, glutamate.
Glutamate is the brain's most abundant excitatory neurotransmitter. The critical nursing knowledge here really relates to neurotoxicity.
Meaning it can actually poison the brain.
Yeah, at normal levels, it's vital for memory and learning. But at high levels, glutamate actually becomes toxic to the neurons. This neurotoxicity is a major factor in brain damage from strokes, chronic alcohol withdrawal, and degenerative diseases like Alzheimer's.
Okay, so we've got these keys floating in the synapse, unlocking doors, but they can't just stay in the lock forever, right? I mean, the dopamine key stays in the lock. The brain just keeps hallucinating endlessly. How does the brain clean up the synapse?
There are 2 primary cleanup mechanisms, and you really must understand these because they are exactly what our medications manipulate. The first is reuptake.
I picture reuptake as the brain basically taking a broom and sweeping up all the extra keys in the synapse and pulling them back into the original neuron to be stored in little vesicles for later use.
That is exactly what happens. The neuron just reabsorbs its own neurotransmitter. The second mechanism is enzymatic degradation.
Okay, what's that?
Well, instead of recycling the keys, the body releases specific enzymes into the synapse to basically hunt them down and destroy them. And the most important one for our purposes is monoamine oxidase, or MAO.
So MAO is essentially a chemical key shredder.
Yes, it metabolizes and inactivates the neurotransmitters so they can't keep firing.
Got it. So if a patient has a mental illness, it means this whole system is just out of whack. Either the brain isn't making enough keys, the locks are broken, the broom is sweeping too fast, or the shredder is working overtime. But why does the system break down? Because for a long time, society viewed mental illness as like a character flaw, a lack of willpower.
And tragically, that stigma still dangerously persists today. But the neurobiology proves otherwise. We know genetics play a massive role. Through family and twin studies, we've identified true genetic vulnerabilities.
Right.
For instance, the ELSI program through the Human Genome Project is actively mapping genes like SRL1, which is strongly linked to late-onset Alzheimer's.
But it's rarely just one isolated gene causing a disorder, right? It's usually a genetic loaded gun, and then the environment pulls the trigger. Yeah. Which brings us to the psychoimmunology aspect. The idea that inflammation and infection can cause psychiatric symptoms is just mind-blowing to me.
It represents a massive paradigm shift. Psychoimmunology studies how psychological stress, immune function, and neurological health all intersect. We are finding that chronic systemic inflammation physically alters neurotransmitter function.
Really?
Yes. That's why profound mood dysregulation is so incredibly common in patients with autoimmune disorders like lupus or multiple sclerosis.
The sources also point to maternal bacterial and viral infections during pregnancy. Like, a severe infection in utero can actually alter the fetal brain development in a way that dramatically elevates the child's risk of developing schizophrenia 20 years later.
Which completely shatters the idea of mental illness as a behavioral choice. It is a biological, physiological condition.
Right. And if it's a physiological condition, we need to be able to see it. So let's talk about brain imaging. The NCLEX absolutely loves testing the limitations of imaging. How do we differentiate between structural and functional imaging?
Structural imaging provides a photograph of the brain's architecture. This is your CT scan and your MRI. A CT uses serial X-rays to create a cross-section, and an MRI uses powerful magnetic fields and radio waves.
And what are we looking for with those?
They're brilliant for spotting physical anomalies like a tumor, a hemorrhage, or, the enlarged brain ventricles we often see in chronic schizophrenia.
So structural imaging checks the framing of the house. Like, are the walls where they should be? Is the roof intact?
Yes, perfect analogy. Functional imaging, however, is your PET scan and your SPECT scan. These look at the actual physiological activity of the brain. They inject a radioactive tracer into the patient's bloodstream and then monitor how the brain metabolizes glucose or how blood flows while the patient performs cognitive tasks.
So that's checking the electricity in the house. Which rooms are lighting up when the patient tries to solve a math problem?
Exactly. Now, the critical exam logic here, students often think we use PE scans to diagnose depression or anxiety on a daily basis. We do not.
Because they're too expensive.
Yes. Functional imaging is incredibly expensive, requires radioactive material, and is largely reserved for advanced research or highly specific diagnostic mysteries, like identifying the specific amyloid plaques of Alzheimer's disease. You will not order an $8,000 PET scan to diagnose acute major depressive disorder on a medical surgical floor.
Okay, we've built the foundation. We know the hardware, the software, and how to image the brain. Now we enter the pharmacology. We're going to look at how we artificially pick those locks, hide the broom, and break the key shredders to save a patient's life.
Let's do it.
Let's tackle the heaviest hitters first: antipsychotics and schizophrenia.
To understand antipsychotics, you really have to understand the nightmare that was psychiatric care before they existed. Prior to the 1950s, if a patient developed severe treatment-resistant schizophrenia, the interventions were barbaric.
What kind of things were they doing?
We used insulin shock therapy to induce comas. We used brutal physical restraints, and tragically, we used prefrontal lobotomies, physically severing the connections in the frontal lobe to render the patient docile.
So they were just warehouse asylums. There was no actual chemical treatment.
None. Until 1952, when a drug called chlorpromazine, or thorazine, was developed. It was initially designed as a surgical anesthetic, but doctors noticed it had this profound calming effect. When administered to psychotic patients, their hallucinations began to fade. The modern era of psychopharmacology was basically born overnight.
So how did Thorazine actually work? What was it doing in the brain?
Thorazine and the other first-generation or conventional antipsychotics that followed, like haloperidol, which is Haldol and fluphenazine, are potent dopamine antagonists. They forcefully block the D2, D3, and D4 dopamine receptors.
So they put a piece of tape over the lock so the dopamine key can't get in.
Yes. And we need to get slightly into the weeds of pathophysiology here to understand the side effects, because this is where clinical judgment lives or dies. The brain has 4 distinct dopamine pathways.
Okay, lay them out for me.
First is the mesolimbic pathway. In a patient with schizophrenia, this pathway is flooded with too much dopamine. This hyperdopaminergic state causes the positive symptoms, the auditory hallucinations, the paranoid delusions, the disorganized speech.
And so when haloperidol blocks dopamine here,
The voices stop. The medication is highly effective.
that sounds like a total victory. So what's the problem?
The problem is that haloperidol isn't a smart bomb. It's a carpet bomb. It blocks dopamine everywhere, including the second pathway, the nigrostriatal pathway.
And what does that pathway do?
This pathway runs straight to the cerebellum and the basal ganglia, which, as we discussed earlier, need dopamine to coordinate smooth physical movement.
Oh, wow. So by fixing the hallucinations in one part of the brain, we completely shut down the movement centers in another part.
Yes. And this blockade causes extrapyramidal symptoms, or EPS. This is a massive, massive area for nursing assessment. EPS is an umbrella term for 3 horrifying neurological side effects.
Let's paint the clinical picture for you guys listening. A patient has been on haloperidol for 3 days. You walk into their room. What does the first type of EPS, acute dystonia, look like?
It is a terrifying crisis for the patient. Acute dystonia is a sudden, severe, sustained contraction of the muscles, usually in the head and neck. You will see a patient whose neck is violently twisted to one side. That's called torticollis.
Oh, man.
Yeah, their tongue might be thick, protruding, and actually obstructing their airway. In the most dramatic cases, they experience an oculogyric crisis, where the muscles of the eyes spasm and the eyeballs lock upward into the ceiling. The patient is fully conscious, terrified, and literally cannot control their body.
As a nurse, you see that happening. It looks like a seizure or a stroke. What is your immediate priority intervention?
You do not wait. You immediately administer an IM or IV anticholinergic medication. The standard protocol is benztropine, brand name Cogentin, or diphenhydramine, which is Benadryl.
Just normal Benadryl.
Yes. By blocking acetylcholine, you rebalance the motor system. Within minutes of that injection, the muscles relax, the eyes roll back down, and the patient can breathe normally.
That is just the power of pharmacology right there in real time. What's the second type of EPS?
Pseudoparkinsonism. The blockade of the nigrostriatal pathway perfectly mimics Parkinson's disease. The patient develops a stiff, stooped posture, a slow, shuffling gait. Their face loses all expression, becoming mask-like. They drool. They develop a resting, pill-rolling tremor in their thumbs and fingers.
And what's the intervention for that?
We either advocate to lower the antipsychotic dose, switch them to a different drug class entirely, or we add a scheduled daily oral anticholinergic like Cogentin to keep those symptoms at bay.
Okay, and the third type of EPS, this one is often cited as the #1 reason patients refuse to take their medications right.
Yes, akathisia. It is a state of agonizing, relentless internal restlessness. The patient feels a horrific physical compulsion to move.
What does that look like on the floor?
They will pace the halls endlessly. They shift their weight from foot to foot. They cannot sit in a chair for more than 30 seconds. It's incredibly distressing, and patients often describe it as feeling like they are crawling out of their own skin. We treat this with beta blockers, anticholinergics, or sometimes a short course of benzodiazepines.
Now, what happens if a patient stays on these conventional antipsychotics for years? Like, the dopamine locks are permanently jammed.
They develop tardive dyskinesia, or TD. This is a syndrome of involuntary repetitive movements, primarily of the face, mouth, and tongue. You see constant lip smacking, tongue thrusting, chewing motions, and facial grimacing.
And the terrifying part about TD is that it's irreversible, right? Even if you stop the Haldol, the movements don't go away.
Traditionally, yes, it was considered entirely irreversible, which is why diligent nursing assessment is absolutely critical. We use the AIM scale, the Abnormal Involuntary Movement Scale, to assess patients every few months to catch the very first microscopic tongue twitches.
But there are new treatments now.
Recently, yes, there has been a breakthrough. The FDA approved VMAT2 inhibitors like valbenazine, brand name Ingrezza. These drugs deplete dopamine in the specific nerve terminals causing the movements, offering the first real treatment for TD.
Okay, We just spent a long time discussing EPS, which causes intense muscle rigidity and spasms. But I want to go back to the scenario I opened the show with. The 24-year-old in the ER, stiff as a board, sweating, fever of 104. That wasn't just EPS. That was neuroleptic malignant syndrome, NMS.
Yes, the big one.
How does a nurse or, a nursing student staring at a multiple choice question differentiate between the stiffness of EPS and the stiffness of fatal NMS?
This is one of the absolute highest yield safety concepts in psychiatric nursing. Both conditions involve severe muscle rigidity, but NMS is a systemic, life-threatening autonomic meltdown.
So what are the distinguishing factors?
Hyperpyrexia, a massive fever, often over 103 or 104 degrees. You will also see autonomic instability. Their blood pressure will wildly fluctuate from hypertensive crisis to hypotensive shock. They will be profusely sweating or diaphoretic. They'll be pale, tachycardic, and rapidly descending into delirium and stupor.
And biologically, the extreme muscle rigidity is physically breaking down the muscle tissue, right?
Yes, which leads to another key diagnostic marker, massively elevated creatine phosphokinase, or CPK levels, in the blood. This represents profound muscle destruction, which can quickly lead to acute renal failure as the kidneys try to filter out the destroyed muscle proteins.
So your patient is burning up, stiff as lead, confused, with a wildly swinging blood pressure. What is your priority nursing action? Is it Benadryl like we used for the dystonia?
Absolutely not.
Yeah.
The priority above all else is to immediately discontinue all antipsychotic medications. Do not give another dose.
And then what?
You then initiate intensive supportive medical care, 4V fluids to flush the kidneys and prevent renal failure, cooling blankets and ice packs for the hyperthermia, and potentially administering medications like dantrolene, which is a direct-acting muscle relaxant, or bromocriptine, a dopamine agonist, to try and override the blockade. NMS has a high mortality rate even with pristine care.
It's just astounding how much collateral damage blocking dopamine causes, which I guess led to the development of the second generation, or atypical antipsychotics, in the 1990s. Drugs like clozapine, risperidone, and olanzapine.
The atypicals revolutionized care again. They are much weaker D2 antagonists, meaning they don't block dopamine nearly as aggressively in the movement centers, which dramatically reduces the risk of EPS and TD.
That's a huge win.
It is. Furthermore, they also block serotonin reuptake. This dual action profile makes them incredibly effective at treating not just the positive symptoms of schizophrenia, the hallucinations, but also the negative symptoms, like the profound apathy, the social withdrawal, the flat effect, which conventional drugs just couldn't touch.
So we traded the movement disorders for a new set of problems.
Yeah.
Metabolic syndrome.
Yes. The underlying mechanism here involves the atypical antipsychotics inadvertently blocking other receptor sites, specifically the 5-HT2C serotonin receptor and the histamine H1 receptor.
And what happens when you block those?
You completely deregulate the brain's satiety center. The patient experiences ravenous, uncontrollable hunger. Additionally, these drugs interfere with intracellular insulin signaling.
So the patient is eating constantly, and their body can't even process the sugar.
Exactly. This leads to metabolic syndrome, rapid and massive weight gain, new onset type 2 diabetes, severe dyslipidemia with skyrocketing cholesterol and triglycerides, and hypertension.
What are the nursing priorities here? We can't just let them develop lethal heart disease.
You must take baseline measurements before they start the drug and then strictly monitor them. You track their BMI, you order fasting blood glucose and A1C levels, you check lipid panels, and you engage in heavy patient education regarding diet, exercise, and lifestyle modifications, though, frankly, it is an incredibly uphill battle against the neurochemistry.
There's one specific atypical antipsychotic that carries an entirely different, terrifying black box warning: clozapine.
Clozapine is arguably the most effective antipsychotic in existence for treatment-resistant schizophrenia. It works when literally nothing else does. But it has a massive, potentially fatal side effect: agranulocytosis.
Wiping out the white blood cells.
Complete destruction of the absolute neutrophil count. It leaves the patient entirely defenseless against infection. A simple cold can become a fatal pneumonia in hours. Because of this, clozapine is tied to one of the strictest FDA REMS risk evaluation and mitigation strategy programs in medicine.
What does that strict protocol look like for the nurse administering it?
You cannot physically obtain the pill from the pharmacy without a corresponding lab draw. The patient must have a baseline white blood cell count and absolute neutrophil count before starting. Then, they must have their blood drawn every single week for the first 6 months of treatment.
Wow, every week?
Yes. If the labs are normal, they get 1 week of pills. If a patient on clozapine ever complains of a sore throat, a fever, or malaise, that is an absolute priority 1 red flag. You hold the medication, isolate the patient, and draw stat labs.
Let's talk about some of the newest developments. Schizophrenia treatment remained relatively stagnant for a while, but the sources highlight some fascinating new drugs. Lybalvi and Cobenfy. Let's start with Lybalvi.
Lybalvi is an ingenious attempt to solve the metabolic crisis. It combines olanzapine, which is an atypical antipsychotic notorious for extreme weight gain, with samidorphan, which is an opioid antagonist.
Wait, an opioid antagonist like Narcan, why mix that with an antipsychotic?
By blocking the mu-opioid receptors, samidorphan actually blunts the brain's reward pathway associated with eating. It effectively neutralizes the uncontrollable hunger caused by the olanzapine.
But there's a massive catch for the nurse assessing the patient.
Right. A life-threatening catch.
Right.
Because it contains a powerful opioid antagonist, if you administer Lybalvi to a patient who is actively using opioids, whether that's heroin, fentanyl, or prescription oxycodone, it will instantly rip the opioids off the receptors and precipitate sudden, violent, full-blown opioid withdrawal. The patient can suffer extreme dehydration, cardiac stress, and potentially death. You must conduct a rigorous substance abuse assessment and ideally a urine drug screen before ever giving this drug.
And then there's Cobenfy, which was just approved. This feels like the first true paradigm shift since Thorazine.
It is historic. Cobenfy, which is a combination of xanomeline and trospium chloride, is the very first antipsychotic that does not target dopamine receptors. Instead, it targets muscarinic cholinergic receptors.
So it completely bypasses the dopamine pathways. No EPS, no tardive dyskinesia.
In clinical trials, it showed virtually zero dopamine-related side effects and no metabolic weight gain. It controls the psychosis through an entirely different neurochemical pathway.
That's incredible, but it must have some side effects.
It does.
Because
it manipulates the cholinergic system, it has its own side effect profile, primarily severe gastrointestinal issues, nausea, and hypertension. It is contraindicated in patients with urinary retention or untreated glaucoma, but it represents a massive leap forward.
Let's wrap up antipsychotics by discussing administration and special populations. Medication non-adherence is a hallmark of schizophrenia. I mean, the paranoia often makes the patient believe the pills are poison, so we use depot injections.
Depot injections are long-acting, time-release intramuscular medications. Instead of relying on a patient to take a pill every morning, the nurse administers an IM injection of a drug like Invega Sustenna or Risperdal Consta into the deltoid or gluteal muscle once a month, or even once every 3 months. It essentially guarantees compliance.
But there is a specific one with a major REMS requirement, Zyprexa-Relprev.
Yes, the long-acting form of olanzapine. It carries a risk of post-injection delirium and sedation syndrome. In rare cases, the medication absorbs into the bloodstream too rapidly, causing profound sedation, ataxia, confusion, and progressing to respiratory depression or cardiopulmonary arrest.
So what's the nursing protocol there?
The REMS requires that the patient be observed in a clinical setting by a healthcare professional for 3 continuous hours after the injection. They cannot leave until they are assessed as fully alert and symptom-free.
And finally, the overarching black box warnings for all antipsychotics. What populations are at the highest risk?
You must remember 2 major warnings. First, using any atypical antipsychotic in elderly patients with dementia-related psychosis increases their risk of mortality, usually from sudden cardiovascular events or infectious pneumonias. We use them as an absolute last resort when the patient is a severe physical danger to themselves or others.
And the second warning?
Second, certain antipsychotics, specifically ziprasidone, brand name Geodon, cause QT prolongation.
The electrical recharging cycle of the heart.
Yes, it prolongs the repolarization phase. This creates a vulnerability where a secondary electrical impulse can trigger a lethal ventricular arrhythmia known as torsades de pointes, leading to sudden cardiac death. As a nurse, you never give Geodon to a patient with a history of QT prolongation, recent myocardial infarctions, or uncompensated heart failure. An ECG prior to administration is standard practice.
Okay. We just spent a massive amount of time on how to bring an overactive, psychotic, hallucinating brain down. We mapped the dopamine pathways, the terrifying side effects of locking them up, and the metabolic fallout. I want to completely shift gears.
Right.
Let's move to the exact opposite problem. What happens when the brain is profoundly underactive? The patient is lethargic, hopeless, and physically unable to get out of bed. We're looking at major depressive disorder, and we need to drag the brain's energy back up. Let's tackle antidepressants.
Antidepressants primarily interact with two neurotransmitters, serotonin and norepinephrine. Unlike antipsychotics, which block the locks, antidepressants generally work by hiding the broom. They inhibit the reuptake process.
They stop the original neuron from sweeping up the serotonin, leaving a massive amount of the chemical floating in the synapse to continuously bombard the next neuron, artificially elevating the mood.
Precisely. And today, the undisputed first-line treatment for depression and chronic anxiety disorders are the SSRI selective serotonin reuptake inhibitors.
Yeah.
Drugs like fluoxetine, which is Prozac, sertraline, which is Zoloft, and acetylopram or Lexapro.
And they're called selective because
They are selective because they only hide the broom for serotonin, leaving the other neurotransmitters largely alone. This targeted approach dramatically reduces the severe side effects seen with older drugs.
they're generally safe, but they carry one of the most paradoxical, terrifying black box warnings in all of pharmacology, the suicide paradox.
This is a critical concept for clinical judgment. When a patient is in the depths of severe major depressive disorder, they often suffer from profound psychomotor retardation. They lack the physical energy to shower, eat, or crucially to construct and execute a suicide plan.
But then they start an SSRI.
And here is the danger. Antidepressants do not work instantly. It takes 2 to 4 weeks for the synaptic changes to translate into an elevated, hopeful mood. However, the patient's physical energy returns much faster, often within the first week.
I'm going to play the role of the overwhelmed student here and offer some serious pushback. If the medication we give to treat depression actually provides a suicidal patient with the sudden physical energy required to hang themselves or overdose, how is that ethical? How does a provider justify sending a severely depressed patient home with a bottle of pills that might facilitate their death?
It is the ultimate clinical bind, and it's an excellent question. It's why the ethical principle of the least restrictive environment clashes heavily with the mandate for patient safety. The alternative, locking every depressed patient in an inparent psychiatric ward for 4 weeks while the medication kicks in, is a massive violation of autonomy and practically impossible due to bed shortages.
So what's the compromise?
The ethical compromise relies entirely on the nurse and the outpatient support system.
Meaning hypervigilant assessment.
Exactly. You do not just hand them the prescription and schedule a follow-up for a month later. The highest risk of suicide is in those first 2 weeks. As a nurse, your therapeutic communication must be direct and unflinching. You do not ask, "Are you feeling sad?" You ask, "Are you currently having thoughts of harming yourself? Do you have a plan? Do you have access to firearms or a stockpile of pills?"
You have to be that blunt.
Yes, you engage the family. You create a safety plan. You are the bridge keeping them alive until the mood elevation finally catches up to the physical energy.
That is heavy. Now, assuming they get past that window, what are the chronic daily side effects of SSRIs?
Because serotonin receptors exist throughout the body, particularly in the gut, the initial side effects are often nausea, mild agitation, and insomnia. But the two side effects that cause massive noncompliance are relentless weight gain and severe sexual dysfunction, specifically anorgasmia or a complete loss of libido.
And people probably don't want to talk about that.
Right. Patients will often quietly stop taking the medication because of this, so the nurse must proactively and delicately ask about it.
Let's look at the older classes of antidepressants. Before SSRIs, we used cyclic or tricyclic antidepressants, TCAs, drugs like amitriptyline or impramine.
TCAs inhibit the reuptake of both serotonin and norepinephrine, but they are dirty drugs, meaning they inadvertently block cholinergic, histaminic, and alpha-adrenergic receptors as well. This causes an intense anticholinergic toxidrome.
The classic mnemonic. Blind as a bat, mad as a hatter, red as a beet, hot as a hare, dry as a bone, the bowel and bladder lose their tone, and the heart runs alone.
Exactly. Blurred vision, delirium, flushing, hyperthermia, dry mouth, profound constipation, urinary retention, and tachycardia. But the most critical reason TCAs have fallen out of favor is their lethality.
Because of overdose risk.
Yes. A patient can easily successfully commit suicide by overdosing on a relatively small amount of their own TCA prescription, as it causes fatal cardiac dysrhythmias and intractable seizures. Prescribing a TCA to a suicidal outpatient is an enormous risk.
Which brings us to the third class, the MAOI's monoamine oxidase inhibitors, drugs like phenelcine and tranylcypromide. We talked earlier about MAO being the chemical key shredder. These drugs destroy the shredder.
Yes. By inhibiting the MAO, enzyme, dopamine, serotonin, and norepinephrine build up to massive levels in the synapse. They are incredibly powerful antidepressants.
But they come with a dietary restriction so severe it almost sounds like a joke until you understand the biology.
the hypertensive crisis. To understand why this happens, we must look at the pathophysiology of an amino acid called tyramine. Tyramine is naturally found in certain aged and fermented foods. Usually, the MAO enzyme in your gut and liver shreds the tyramine before it can enter your bloodstream.
But if the patient is taking an MAOI, the shredder is broken. The tyramine gets into the blood. What does it do?
Tyramine is structurally very similar to norepinephrine. Once in the bloodstream, it travels to the sympathetic nerve terminals, forces its way inside, and violently shoves massive amounts of stored norepinephrine out into the circulation. Yeah, this massive flood of norepinephrine causes explosive systemic vasoconstriction.
The blood vessels clamp down instantly.
The patient's blood pressure skyrockets to 220 over 140. They experience a blinding occipital headache, severe diaphoresis, tachycardia, and a stiff neck. If untreated, this leads to intracranial hemorrhage, a massive stroke and death.
So to prevent a stroke, they cannot eat any tyramine. What is on the forbidden food list?
Any aged mature cheeses, cheddar, Gouda, Parmesan, blue cheese, Swiss, aged cured or smoked meats like pepperoni, salami, summer sausage, and prosciutto, fava beans, overripe avocados, tap or draft beers, red wine, soy sauce, and Marmite.
Again, I have to play the skeptic. If a patient is severely depressed, possibly struggling with self-care and impulse control, and eating a slice of pepperoni pizza and a draft beer could literally cause their brain to hemorrhage, why are MAOIs still on the market?
It's all about treatment-resistant atypical depression. There is a subset of patients who have tried 5 different SSRIs, 2 SNRIs, a TCA, and electroconvulsive therapy, and they are still catatonic with depression.
So it's a last resort.
For those patients, an MAOI is the last line of defense. It can genuinely be the only thing that works. The provider just has to be absolutely certain the patient possesses the cognitive capacity and discipline to follow the diet.
Before we move off antidepressants, we need to talk about the drug-to-drug interactions. Serotonin syndrome.
Serotonin syndrome is the result of an absolute overload of serotonin in the central nervous system. It usually happens when a provider switches a patient from an SSRI to an MAOI without allowing a sufficient washout period, usually 2 to 5 weeks depending on the half-life of the drug, for the first drug to clear the system. Or if a patient mixes an SSRI with an illicit drug like MDMA or certain herbal supplements.
Paint the clinical picture of serotonin syndrome. What does the nurse see?
It is a spectrum of toxicity. It starts with agitation, confusion, and shivering. It progresses to severe diaphoresis, hyperthermia, tachycardia, and GI distress like diarrhea. Neurologically, you see hyperreflexia, extremely exaggerated reflexes, and myoclonus, which are sudden, involuntary muscle jerks. In the final, severe stage, it leads to status epilepticus, coma, and death.
And the intervention.
The intervention is to stop the offending agents immediately, provide supportive care, and sometimes administer serotonin antagonists like cyproheptadine.
There are a few unique atypical antidepressants that the NCLEX loves to test because of their specific red flags. Let's run through them. Bupropion or Wellbutrin.
Bupropion is unique because it primarily inhibits the reuptake of dopamine and norepinephrine, leaving serotonin alone. This is fantastic because it doesn't cause the weight gain or the sexual dysfunction of SSRIs. It's also used to help people quit smoking. However, the massive red flag is that it significantly lowers the seizure threshold.
Meaning it makes it much easier for the brain to have a seizure.
Yes. It is strictly contraindicated in patients with a history of epilepsy, severe head trauma, or eating disorders like anorexia and bulimia, because the electrolyte imbalances in eating disorders already predispose the patient to seizures, and the dose should never exceed 450 milligrams a day.
What about trazodone?
Trazodone is a weak antidepressant, but it is highly sedating, so it is prescribed incredibly often off-label for insomnia. The unique severe red flag here is priapism, a prolonged, painful erection lasting longer than 4 hours. It is a urological emergency requiring immediate medical intervention, sometimes surgical, to prevent permanent tissue damage and impotence.
And nafazodone.
Nafazodone carries a black box warning for sudden, life-threatening hepatotoxicity. It can destroy the liver rapidly, so hepatic enzyme monitoring is mandatory.
We've covered dragging the mood up, but what happens when the mood hasn't just left the basement? It's blasted through the roof and is hovering in the stratosphere. How do we bring a manic patient back to earth without crashing them into a depression? This is the domain of bipolar disorder and mood stabilizers.
Bipolar disorder is characterized by massive, destructive swings in energy and mood. During a manic episode, the patient is euphoric, grandiose, hypersexual, and impulsive. They don't sleep for days. Their thoughts race so fast their speech becomes pressured and incoherent. Without intervention, acute mania is physically exhausting and incredibly dangerous due to the extreme impulsivity.
And the gold standard to stop the mania and stabilize the mood in the middle is lithium.
Lithium has a fascinating history. It was discovered to have psychiatric properties in the late 1940s by an Australian psychiatrist named John Cade. He was actually injecting the urine of manic patients into guinea pigs, hypothesizing that mania was caused by a toxic substance.
As you do.
Right, and the guinea pigs died of uric acid toxicity, so he added lithium salts to the uric acid to make it more soluble, hoping to protect them. Instead of getting manic or dying, the guinea pigs became profoundly calm and docile.
That is wild. He accidentally discovered the greatest mood stabilizer in history because he was trying to dissolve guinea pig urine. So how does lithium actually work in the human brain?
Lithium is unique. It's an element, a simple salt. It doesn't bind to receptors like other psychotropics. It operates intracellularly. It passes through the sodium channels of the neuron and alters the secondary messenger systems inside the cell, modulating the release of serotonin, norepinephrine, and dopamine, while simultaneously increasing the inhibitory effects of GABA.
But because it's a salt, it acts just like sodium in the body. And this is where the danger lies. Let's build out the SUV analogy. Treating a patient with lithium is like trying to park a massive SUV in a tiny one-car garage.
The therapeutic index for lithium is incredibly narrow. We want the serum lithium level hovering right around 1.0 MEQL. If the level drops below 0.5, if you park too far to the left, the drug isn't working and the patient swings back into acute mania.
But if you pull the SUV too far to the right,
You crash right through the drywall into the living room. That is lithium toxicity. If the level creeps up to 1.5, you start seeing toxicity. At 2.0, it's severe. At 3.0, the patient is in a coma, their kidneys are failing, and they require emergency hemodialysis to pull the metal out of their blood.
so how does a patient accidentally slide into toxicity? Does it just build up over time?
It all comes down to the kidneys and hydration. The proximal tubule in the kidney cannot distinguish between a sodium ion and a lithium ion. They look identical to the body.
Uh-oh.
Yeah. If a patient becomes dehydrated, maybe they're running a marathon on a hot day, or they catch the stomach flu and are vomiting, their blood sodium drops. The kidneys panic and say, we need to reabsorb all the sodium we can find to save the body. But because they can't tell the difference, they reabsorb all the lithium instead.
And the blood lithium levels skyrocket, crashing the SUV through the wall.
Exactly. Therefore, the nursing education is critical. You must teach the patient to maintain a consistent fluid intake, 2 to 3 liters a day, and a consistent dietary sodium intake. If they suddenly cut salt out of their diet to lose weight, their lithium levels will spike to toxic levels.
The NCLEX frequently tests a nurse's ability to differentiate between the expected, annoying side effects of lithium and the red flag toxic effects. What is the difference?
Expected side effects, which we educate the patient to tolerate, include a fine, barely noticeable hand tremor, mild nausea, a metallic taste in the mouth, and polyuria and polydipsia, meaning they pee more and drink more water.
But the red flags of toxicity.
The red flags are severe, explosive diarrhea, uncontrollable vomiting, severe muscle weakness to the point they can't stand up, gross ataxia, meaning they stumble like they are heavily intoxicated, a coarse, violent tremor, slurred speech. If you see these signs, you withhold the next dose of lithium, notify the provider immediately, and draw stat lithium levels.
Now, lithium is the gold standard, but it's hard on the kidneys and the thyroid. If a patient can't tolerate it, what is the backup plan?
We use anticonvulsants. Drugs originally developed to stop the physical electrical storms of seizures in the brain are prescribed off-label to stop the emotional storms of mania.
This is based on the kindling theory, right?
Yes. Think of building a fire. You don't just hold a match to a massive log. You start with tiny twigs, kindling, to build the heat until the log catches. In bipolar disorder, minor psychological stressors or subthreshold electrical stimulations in the brain act as kindling. Over time, these minor stimulations snowball and ignite a full-blown manic episode. Anticonvulsants raise the brain's threshold, effectively removing the kindling so the fire can't start.
The heavy hitters here are valproic acid, carbamazepine, and lamotrigine, and they all come with terrifying black box warnings. Let's start with valproic acid or Depakote.
Valproic acid is highly effective, but it is notoriously hepatotoxic. It can cause sudden, fatal liver failure, especially in young children. You must monitor liver function tests constantly. It can also cause life-threatening hemorrhagic pancreatitis, and it is highly teratogenic. If a pregnant woman takes it, it vastly increases the risk of neural tube defects like spina bifida in the fetus.
What about carbamazepine or Tegretol?
Carbamazepine can cause aplastic anemia and a granulocytosis. Just like clozapine, it can wipe out the bone marrow's ability to produce white blood cells. Baseline and periodic hematologic monitoring is mandatory. It also undergoes autoinduction, meaning over time, the drug stimulates the liver enzymes to destroy the drug faster, so the nurse must monitor for returning manic symptoms as the drug essentially eats itself.
Lamotrigine or Lamictal?
Lamotrigine is excellent for the depressive phase of bipolar disorder, but it carries a massive risk for Stevens-Johnson syndrome.
I've seen pictures of Stevens-Johnson in textbooks. It looks like a severe burn victim.
It is a severe, life-threatening, immune-mediated hypersensitivity reaction. The patient develops a fever, a blistering rash, and the epidermal layer of the skin actually detaches and sloughs off. It is incredibly painful and highly lethal due to infection and fluid loss.
So what's the nursing priority?
The nursing priority is absolute. If a patient is starting lamotrigine and reports even a microscopic new skin rash, you tell them to stop the medication immediately and go to the emergency room.
The theme of this entire masterclass seems to be psychopharmacology works miracles, but it is constantly trying to destroy the liver, the blood, or the skin.
That is exactly why the nurse is the ultimate safety net.
Let's pivot to our final major categories: anxiolytics, stimulants, and disulfiram. Calming, focusing, and deterring. Let's start with the anxiolytics. When someone is having a massive panic attack, their chest is tight, they think they're having a heart attack, the locus coeruleus is screaming, we reach for the benzodiazepines.
Drugs like alprazolam, which is Xanax, diazepam, which is Valium, and lorazepam, or Ativan, they are the heavy artillery for acute anxiety.
Mechanistically, how do they stop a panic attack so quickly?
They enhance the effects of GABA. They bind to a specific site on the GABA-A receptor, which opens up chloride channels. Negatively charged chloride ions flood into the neuron, hyperpolarizing it. This makes it incredibly difficult for the neuron to fire. The entire central nervous system slows down, the heart rate drops, the breathing regulates, and the panic dissolves.
They're incredibly effective, but they have a massive dark side.
Physical dependence and addiction. The brain quickly adapts to the constant flood of chloride. If you stop the benzodiazepine abruptly, the brain is left with downregulated GABA receptors and unopposed glutamate, the excitatory neurotransmitter.
The emergency brake is gone, and the gas pedal is stuck to the floor.
Exactly. Abrupt withdrawal from benzodiazepines is a medical emergency. It causes severe rebound anxiety, tremors, hallucinations, and intractable, potentially fatal seizures. They must be tapered down slowly over weeks or months under strict medical supervision.
They also have a lethal synergy with alcohol.
They're heavily cross-tolerant with alcohol. Benzodiazepines drastically potentiate the effects of alcohol. One drink feels like 3. Taking a Xanax and drinking a few beers causes profound central nervous system depression, leading to respiratory arrest and death. Patient education must be absolute. 0 alcohol.
Is there an alternative for chronic anxiety that doesn't carry the risk of addiction and fatal withdrawal?
Yes, buspirone, brand name Buspar. It is a non-benzodiazepine anxiolytic. It doesn't touch GABA. It acts as a partial agonist at serotonin receptors. It causes 0 physical dependence, no withdrawal, and it doesn't depress the central nervous system, so it's much safer.
The catch being?
It is incredibly slow. It takes 2 to 4 weeks of daily dosing to build up to a therapeutic level. So if a patient is having a panic attack right now, buspirone is useless. But for chronic, generalized anxiety disorder, it is a much safer long-term option.
Okay, we've calmed the brain down. Now let's stimulate it.
Yeah.
ADHD, attention deficit hyperactivity disorder. The gold standard treatments are central nervous system stimulants. Methylphenidate, like Ritalin, and amphetamines, like Adderall.
Which presents a massive physiological paradox that students struggle to understand.
Right. If a child is bouncing off the walls, cannot sit still, and is hyperactive, why on earth are we giving them pharmaceutical-grade amphetamines? That sounds like throwing gasoline on a fire.
It does, until you understand the pathophysiology of ADHD. The hyperactive behavior isn't because the whole brain is running too fast. It's because the inhibitory centers of the brain, specifically the prefrontal cortex, which is supposed to filter out distractions and control impulses, are under-aroused and sluggish. The child is hyperactive because their brain lacks the energy to apply the brakes.
So by giving them a stimulant, we are specifically waking up the prefrontal cortex.
Yes, the stimulant floods the prefrontal cortex with dopamine and norepinephrine. The brakes finally turn on. The child can suddenly filter out the background noise, sit still, and focus on their homework.
That is a brilliant piece of neurobiology. But stimulants have their own issues, particularly in children.
The primary side effects are severe anorexia, weight loss, and insomnia. Over years of use, this can lead to significant growth suppression. The child literally stops growing because they aren't eating or sleeping properly.
What is the nursing intervention for that?
We utilize drug holidays. The medication is not meant to be taken 365 days a year. The child takes the stimulant during the school weeks so they can function academically. But on the weekends, during holiday breaks, and over the entire summer vacation, they do not take the medication. This allows their appetite to return, they eat voraciously, and their body undergoes catch-up growth.
Let's move to our final specific drug. It's a fascinating one used in substance abuse deterrence.
Disulfiram, brand name Antabuse.
Disulfiram is pure chemical aversion therapy used for alcohol use disorder. Its history is also accidental. In the 1930s, workers in the rubber vulcanization industry who were exposed to the chemical tetraethylthiramine disulfide noticed that if they went to the pub after work and had a single beer, they became violently ill.
So scientists isolated it and turned it into a pill. How does it cause such a violent reaction?
Normally, when you drink alcohol, your liver uses an enzyme called aldehyde dehydrogenase to break down acetaldehyde, a toxic byproduct of alcohol, into harmless acetic acid. Disulfiram permanently binds to and destroys that enzyme. So if a patient takes disulfiram and then drinks a beer, the toxic acetaldehyde rapidly accumulates in their bloodstream.
Within 5 to 10 minutes, they experience a horrific reaction. Massive facial flushing, a throbbing, agonizing headache, severe nausea, projectile vomiting, diaphoresis, and severe hypertension. It feels like they are dying. In severe cases, it can trigger cardiovascular collapse and actually kill them.
The psychological deterrence is immense. You take the pill in the morning, knowing that if you drink later that night, you will suffer unimaginably. But the nursing education required here must be monumental because alcohol is hidden everywhere.
The sensitivity is absolute. A patient on disulfiram cannot use alcohol-based mouthwash. They cannot swallow NyQuil or other cough syrups. They cannot use certain cooking extracts like vanilla extract.
What about topical products, like if I use an alcohol-based hand sanitizer in the hospital?
The skin will absorb enough alcohol to trigger the reaction. Hand sanitizers, colognes, aftershaves, even certain shaving creams are strictly forbidden. The nurse must educate the patient to rigorously read the label of every single product they touch or ingest. And crucially, you must never administer the first dose of disulfiram until the patient has a blood alcohol level of absolute 0, usually abstaining for at least 12 hours, otherwise you will trigger the reaction right there in the clinic.
We've covered a staggering amount of pharmacology. But pills don't exist in a vacuum. They are administered to human beings with unique genetics, cultures, and habits. Let's bring this all together under the umbrella of the holistic nurse.
Pharmacology is only half the battle. You have to consider the pharmacokinetics of the individual. For instance, there are massive genetic differences in how diverse populations metabolize drugs. Some ethnic groups have genetic variations in their cytochrome P450 enzymes in the liver. They might be poor metabolizers, meaning a standard dose of an antipsychotic will build up to toxic levels in their blood because their liver can't clear it.
But the sources also warn against racial stereotyping. You can't just look at a patient's ethnicity and assume their metabolic rate.
Exactly. Genetic blending means visual assumptions are dangerous and clinically lazy. The nursing priority is an exhaustive, individualized history. You ask, have you ever had an unusually severe reaction to a normal dose of medication? Do standard pain meds usually not work for you? You listen to their history to guide the dosing.
You also have to ask about herbal supplements. This is a massive trap in the real world and on the NCLEX.
Patients do not view herbal supplements as medicine because they buy them at the grocery store. If you asked, what medications are you on, they will list their prescriptions and stop. You must specifically ask, do you take any herbal supplements, teas, or natural remedies?
Because they chemically clash with psychotropics in terrifying ways. Let's run through the big ones. St. John's wort.
St. John's wort is highly effective for mild depression, but it is a massive enzyme inducer in the liver, meaning it alters how other drugs are metabolized. And if a patient takes it alongside a prescribed SSRI, it pushes their serotonin levels into the stratosphere, causing fatal serotonin syndrome.
Kava and valerian.
Both are used for anxiety and sleep. They enhance GABA. If a patient takes them alongside a prescription benzodiazepine or alcohol, the synergistic effect causes profound, dangerous central nervous system depression.
Ginkgo biloba.
Used for memory enhancement, but it alters platelet function. Combined with SSRIs or blood thinners, it creates a massive bleeding risk. The nurse must uncover these hidden interactions.
Which requires building immense trust with the patient. And that brings us to the most important tool a psychiatric nurse has: their own self-awareness and empathy.
Psychiatric nursing is emotionally grueling. It is incredibly easy to fall into the trap of frustration. You spend weeks stabilizing a schizophrenic patient in the inpatient unit. You get their Haldol levels right, the voices stop, you discharge them. 2 months later, they are readmitted, floridly psychotic, because they stopped taking their pills. The initial human reaction is often, if they would just try harder, if they would just listen, they wouldn't be here.
It feels like a moral failing on the patient's part, a deliberate defiance.
But here is the perspective shift that separates a novice from an expert psychiatric nurse. Reframing non-adherence. We have spent an hour establishing that mental illness is a chronic physiological brain disease, just like severe asthma or type 1 diabetes.
Right. If a diabetic goes into DKA because their pancreas fails, we don't say they lacked willpower.
Exactly. When a patient with schizophrenia stops taking their medication, the non-compliance is rarely a deliberate act of spite. The non-compliance is a symptom of the illness itself. The disease process destroys the frontal lobe's ability to maintain insight. It breeds paranoia that the pills are poison. The severe side effects, the akathisia, the weight gain, the tremors, become unbearable.
So how does the nurse communicate with that patient? You can't just scold them.
Never. You use targeted therapeutic communication. You don't say, "Why did you stop your meds? You know you need them." That creates immediate defensive walls. Instead, you validate and explore. You say, "Tell me what it physically feels like when you take the medication." Or, "It sounds like the restlessness from the pills was incredibly difficult to manage. What concerns do you have about starting a different medication?" You validate their subjective experience and you partner with them to find a solution, like a depot injection or a new drug class.
That empathy, combined with the rigorous scientific knowledge of exactly what that drug is doing to their brain, is what saves lives.
That is the art and science of psychiatric nursing.
We've covered an immense amount of ground today. We navigated the 80-20 rule, recognizing that safety is always the priority. We mapped the dopamine pathways and the terrifying reality of EPS and NMS. We explored the ethical bind of the suicide paradox with SSRIs, the lethal dietary traps of MAOIs, and the razor-thin therapeutic window of lithium. We looked at how to calm a panic attack without causing a fatal withdrawal, and how waking up the prefrontal cortex calms a hyperactive child.
And through it all, we've established that the nurse is not a passive pill dispenser. The nurse is the ultimate vigilant safety net standing between the patient and a lethal chemical reaction.
Which leaves us with a final provocative thought to mull over. We talked about psychoimmunology and genetics at the very beginning. The idea that maternal viral infections or systemic inflammation can physically alter the brain and cause schizophrenia. If we are actively mapping the exact genetic codes that trigger Alzheimer's and proving that these conditions are physiological, are we approaching a future where psychiatric illnesses are no longer treated with carpet-bombing dopamine blockers, but are treated entirely by immunologists and geneticists?
It's the frontier of neuroscience. If we can definitively point to a viral marker or a specific inflammatory protein as the physical root cause of psychosis, it fundamentally changes everything. Society will have no choice but to treat mental illness with the exact same universally accepted compassion as a broken bone or a failing heart.
A future where that X-ray machine isn't broken anymore? Where the diagnostic muddy waters finally clear up? Until then, you have the knowledge, the pathophysiology, and the clinical judgment to navigate the murkiness, to recognize the red flags, and to keep your patients safe. Take these insights into your next clinical rotation. Use them to see the whole patient and absolutely crush that board exam. See you next time on The Deep Dive.